next talk is actually, it's probably not an easy task, as I can appreciate, from the melanoma world. We have a lot of FDA approvals, and the biggest question in our mind is how to sequence the various agents that are available. But we don't have as many available for melanoma as there are for metastatic breast cancer. So I can imagine the task of sequencing things in breast cancer must be incredibly complex. But we have an outstanding speaker to break it down for us. It's my pleasure to introduce Dr. Mark Pegram, who is joining us from the Bay Area, I'm assuming. Dr. Pegram is actually the director of research at breast cancer program at Stanford University. And Dr. Pegram, please educate us on how to sequence optimally in metastatic breast cancer.
Thank you very much indeed for the kind introduction. And I'm so pleased to be back at the foundation meeting again this year. It's been a really exciting meeting over the years, and I've always looked forward to participating. And, it's just a real treat. And I really truly appreciate the invitation. My disclosures are shown at the bottom of the slide, are relevant to this topic, so please take note of that. As you just heard, rightly so, this probably should be an hour to a 90-minute talk, and I've had to really slow it down to just a few topics that are potentially practice changing. And like VK's talk, I'm going to cover not only ASCO proceedings, but also San Antonio, ASCO, New England Journal papers, recent new drug approvals, as well as ESMO. So this is a very, very ambitious agenda indeed for a 30-minute format. And I apologize to any of you if I'm not showing you your favorite abstracts, but just in the interest of time, it won't be possible. So what I would like to cover is the ACAHO20 E2108 trial of surgery versus not for stage 4 breast cancer. I'll talk about the BYLieve study, which is a phase 2 trial of alpelisib following CDK4/6 inhibition. I'll talk about trastuzumab deruxtecan and its new drug approval and important safety information. I'll talk about the tucatinib registrational pivotal trial and also important safety information regarding that drug and an update in its use in CNS metastasis from ASCO 2020. I'll talk about Keynote 355, which is a pembrolizumab plus chemotherapy versus placebo plus chemotherapy comparison in a phase 3 study. And then I'll talk about primary results from Impassion 131, which was meant to be sort of a, a confirmatory trial behind the atezolizumab albumin formulation paclitaxel combination. But in fact, as I'll show you, this ordinary paclitaxel cremophore formulation randomized trial with atezolizumab is in fact a negative study. So that's going to require some thought. And finally, I'll finish on the phase 3 confirmatory trial of sacituzumab govitecan in refractory triple-negative metastatic breast cancer. So I'll start out with ACAHO20 randomized phase 3 trial, the value of early local therapy for the intact primary tumor in patients with metastatic breast cancer. There have been prior studies looking at this very question, one on the left-hand side of the slide from Tata Memorial Hospital in Mumbai. And that was a negative study with no survival advantage for early local regional therapy with surgery and or radiotherapy. Whereas there was a Turkish Federation trial shown on the right-hand side, the Kaplan-Meier analysis showing the top-line results with a 5-year result favoring early local regional therapy in metastatic disease with an overall survival difference of 17% with statistical confidence. So this trial is, for all practical purposes, perhaps a tiebreaker between these two extremes. So here is the study design. It's a little bit complicated. These are patients with de novo stage 4 disease. They're registered. They have optimal systemic therapy based on patient and disease features. If they have no progression or distant disease following 4 to 8 months of therapy, they're then randomized to continue systemic therapy alone with follow-up for 5 years, or be randomized to early or local therapy along with continued systemic therapy thereafter with the same degree of follow-up, and then complete tumor resection with free surgical margins was the goal, as well as post-operative radiotherapy per standard of care. There were 360 patients enrolled, 258 were randomized. Total information of 152 mortality events would have an 85% power to detect a 19% difference in 3-year overall survival. The primary endpoint is overall survival. These are the top line results. I put efficacy in the title in quotes because, as you can see, this is a negative study. The hazard ratio for overall survival was 1.09 with a non-significant p-value. Similarly, the progression-free survival results were also not significant. The author's conclusion was, quote, local regional therapy for primary tumor should not be offered to women with stage 4 breast cancer with the expectation of a survival benefit. And that's a key conclusion. I'll come back to that in just a minute. Now, in terms of the breakdown, in terms of the types of subsets of patients in this trial, there were triple negative patients, HER2 positive and hormone receptor positive indeed. And as you can see in these Kaplan-Meier overall survival probability plots, that the triple negative subgroup on the far left actually had a deleterious effect from early local therapy. And this may be because it's more important for the triple negative subset to have the ongoing pressure of continued systemic therapy. So there may be a disadvantage for delay in access to chemotherapy, perhaps by allowing time for surgery, radiation, and then the healing process before you could start chemo thereafter. At least that's the armchair explanation that's been offered for that subset analysis. Whereas in the HER2 positive group shown in the middle and the hormone receptor positive HER2 negative group shown at the right, there was no difference in outcome with regard to early local therapy or not. So I've shown you the survival data, and this will come up at your tumor boards all the time, whether or not to operate on stage 4 disease. But I'm here to tell you that, in my opinion, overall survival is not the only important endpoint here. And that's underscored by the fact that if you look at the local regional recurrence and progression in this trial, in the ECOG study, it's actually worse in the patients who did not have randomization to early local therapy. And as you know, local regional breast cancer progression can be very problematic, with skin breakdown, drainage, sometimes superinfection, sometimes even bleeding. It can lead to the sort of onchoros phenotype with terrible dermal lymphatic invasion, et cetera. Consequently, it may be for selected patients critically important to still offer early local regional therapy if you think they're at risk for chest wall progression or in-breast progression that's problematic. And so don't discount the possibility of reasonable application of early local regional therapy for such patients. And also there's a subgroup of patients who have psychological damage, if you will, just because they can see or feel their local disease. And that can be sometimes very disturbing psychologically. And if for that reason they need early local therapy, that may also be medically indicated, in my opinion. So the lack of overall survival does not necessarily translate, in my view, to a no-go decision regarding early local regional therapy. So it should be used judiciously on a case-by-case basis, depending on the clinical presentation and the goals of care moving forward. The discussant for the session, Julia White, made a key point about E2108, and that is that it does not apply necessarily to de novo oligometastatic disease, where you might have the opportunity to render these patients with a clinical CR, because those patients have a long-term favorable outcome compared to patients who don't achieve a clinical CR. So for this de novo metastatic, oligometastatic breast cancer setting, where you may be able to render patients NED, no evidence of disease, you should proceed to do that. That is a noble goal, and you should not stall the use of early local regional therapy just because of the ECOG-2108 survival data. Don't use that as an excuse not to treat oligometastatic disease that can be rendered NED. Next, I'll talk about the BYLieve study. This was a study involving alpelisib. Previously in the SOLAR-1 trial, only about 5% of the patients in that trial had prior CDK4/6 inhibition, which begs the question, is alpelisib still efficacious in patients with prior CDK4/6 inhibitor treatment? So this study was designed to look at that very question in a population of PIK3CA mutated hormone receptor positive HER2 negative advanced breast cancers. And so you can see the various cohorts. Cohort A, patients who received CDK inhibition along with an AI. Cohort B, CDK inhibition along with fulvestrant as the immediate prior treatment. And then cohort C was a group of patients who progressed on or after AI and received chemotherapy or endocrine therapy as immediate prior treatment. The primary endpoint is the proportion of patients alive without progression at 6 months in each cohort. The secondary endpoints are shown at the far right-hand side of the slide. These are the top-line data. The primary endpoint was achieved. 50.4% of the patients were alive and without disease progression at 6 months. The lower confidence bound of that for the 95% confidence interval was greater than 30%, which met the protocol specified definition of a positive study. The secondary endpoint, which is the median PFS, was 7.3 months, which is also respectable in this patient population. As compared to the SOLAR-1 data, you can see at the bottom of this slide, about 44% of the patients with PIK3CA mutant disease with prior CDK inhibition with alpelisib plus fulvestrant were alive and disease without disease progression at 6 months. So this data certainly compares favorably to that subset in SOLAR-1 and compares fairly favorably to the intent to treat population in SOLAR-1 indeed. The Kaplan-Meier analysis is shown on the upper right-hand side slide for your consideration as well. You can see most of the responses, all of the responses indeed, were partial responses, and the clinical benefit rate was respectable also at about 45%. Now, this drug, this PIK3CA inhibitor, alpelisib, has important safety data that you must be mindful of. There can be serious adverse events. You can look at the treatment-related serious adverse events in the upper left. About 15.7% had all-grade treatment-related, and 14% of the patients had grade 3 or greater SAEs. Adverse events leading to drug discontinuation was apparent in about 20% of these patients for all-grade toxicities leading to discontinuation, and 18% were treatment-related. Adverse events leading to dose adjustment or interruption was in almost 65% of the patients on the lower left-hand side of the slide. On the right-hand side of the slide, you can see the most common adverse events associated with alpelisib in this trial in cohort A. The most common side effects, of course, are hyperglycemia, which is on-target effect because PI3 kinase AKT pathway regulates insulin responses, as you know. Diarrhea was also fairly common. Skin rash can be common. There's a clinical pearl from this trial that was presented in that prophylactic administration of antihistamines decreased the incidence of grade 3-4 rash from 21.4% down to 10%. So that's a very important point. Also, I recommend early referral to dermatologists if you have rashes that are getting the least bit out of control, because they can also be very helpful in intervening. And these rashes can sometimes be serious, even requiring hospitalization. The rest of the adverse events in greater than 15% of the patients are shown on the right-hand side of the slide in the table for your interest. Next, I'll shift gears and talk about HER2 positive disease for a short time. This is trastuzumab deruxtecan. It's a very interesting HER2 antibody drug conjugate. It is very much distinct from TDM1 in terms of its chemistry and structure. You can see that there are cysteine residues in the trastuzumab antibody backbone to which a topoisomerase 1 inhibitor payload is conjugated. There are 8 of these cysteine residues in the sequence for trastuzumab. So this is site-specific chemistry for the linker payload combination. The linker is also a peptide-based cleavable linker, and that's in contrast to TDM1, which is a stable linker. Also, you'll recall TDM1 has conjugation chemistry to lysine amino acids in the trastuzumab backbone, not cysteines. And there are dozens of lysine amino acids in trastuzumab, and so the conjugation is random. It can be anywhere in the structure of the antibody backbone, whereas these cysteines are in very specific sites. Consequently, the drug-to-antibody ratio for this construct is about 8-to-1, whereas it's only about 3-to-1 for TDM1. Another attribute of this payload is that it's soluble, whereas DM1 is not. So DM1, when it's released from dead cells following TDM1 treatment, it cannot diffuse into neighboring cells and kill those as well, whereas this construct can. This topo1 payload has an important bystander effect, which may account for some of its robust efficacy. This is the DESTINY-01 registrational trial that won FDA approval in 168 patients in a phase 2 study. The dose is 5.4 milligrams per kilogram. confirmed as the recommended phase 2 dose and the FDA approved dose now. These were adult patients with HER2 positive unresectable or metastatic breast cancers with prior TDM1 treatment. You can see that the objective response rate is astonishingly high, the highest ever reported for any HER2 targeted single agent in history, 61%. 11 of those were CRs. The disease control rate, an astonishing 97.3%. So this is a very, very active compound. Recall that in this heavily pretreated patient population, these patients had a median of around 5 to 6 prior lines of therapy for HER2 positive metastatic disease. So this is an extraordinary efficacy signal indeed on the waterfall plot. The FDA label is shown at the bottom. Trastuzumab deruxtecan is an antibody drug conjugate indicated for the treatment of adult patients with unresectable or metastatic HER2 positive breast cancer who have received 2 or more prior anti-HER2 based regimens in the metastatic setting. So be aware that the 2 or more prior lines is a stipulation in the label indication. In terms of consistency of the data, you can see on the forest plot on the left-hand side of the slide that there was consistency with overlapping confidence limits as compared to the all patient population shown at the top. So you can look at any of the subsets and see that the 95% confidence limits comfortably overlap that of the all patient population for comparison. Interestingly, there were about 24 patients in this trial with brain metastasis. They had a similar objective response rate as the intent to treat population, but it is a very small subset with wide confidence limits. The progression-free survival is shown in the upper right-hand side of the slide for your consideration. The median PFS was 16.4 months. The overall survival was astonishingly high in such a heavily pretreated patient population, in my opinion. And you can see that that's on the bottom right-hand side of the slide. So very, very robust efficacy signals for a single agent HER2 targeted antibody drug conjugate. This drug is not without toxicities, however, and these toxicities are distinct from TDM1 toxicities in many ways. There is nausea with this agent, so you do need to use antiemetics. I find that there's delayed nausea in our experience at Stanford with this agent, so be prepared to give patients not only a couple of days of antiemetics, but make sure they have enough for perhaps a few to several days of antiemetic drugs. Fatigue is not uncommon. Alopecia is a feature of this drug in about 50% of patients, and that's also distinct from TDM1, so don't promise anyone they won't have alopecia. The remainder of the adverse events are shown on the left-hand side of the slide. A very important adverse event of special interest, of course, is interstitial lung disease, and I've put the data for you as an insert on the right-hand side of this slide. And you can see that some of these rise even to the level of grade 5, so it's critically important to monitor for any evidence of interstitial lung disease, both in terms of symptomatology, fever, cough, shortness of breath, etc., chest pain, or also radiographic evidence. Whenever you restage these patients, you usually get thoracic CT imaging, so that's a good opportunity to look for any radiographic signs of interstitial lung disease, which may also need intervention. This drug does have dose modification schedules, as shown on the bottom left-hand side of the slide. And the package insert is very clear about when it is necessary to dose reduce for any of the adverse events shown in the above plot. This is the management of interstitial lung disease. Since this is the most important toxicity from a clinical perspective, since it can be severe or even lethal, I wanted to spend a little bit of time on this. So if you see any patient with worsening pulmonary symptoms or radiographic evidence of ILD, then you should confirm this with a high-resolution CT. Consider early pulmonary consultation with a specialist because they may consider bronchoscopy to rule out other causes of pulmonary infiltrates, such as infectious causes. PFTs and pulse oximetry may be indicated, as well as arterial blood gases. And then it is also possible to collect blood and send it to the manufacturer for PK assessment, because this is still ongoing work, and the causes of this interstitial lung disease are still incompletely understood. We do know that HER2 is expressed in pulmonary epithelium. That's based on a publication by Mike Press back in the early 90s. So this may be an on-target effect, perhaps, but I will freely acknowledge that TOPO1 inhibitors also have been shown to have interstitial lung disease as a complication as well. So I don't know whether it may just be a payload effect or a combination of both. So management. For grade 1, you hold the drug treatment. If there's resolution within 28 days, then you can maintain the dose. If it resolves after 28 days of onset, you're to reduce the dose by 1 dose level. And if grade 1 ILD occurs beyond day 22 and has not resolved within 49 days from the last infusion, you should discontinue the drug. The package insert recommends consider corticosteroid treatment as soon as ILD or pneumonitis is suspected, and that includes grade 1, consider corticosteroids. For grade 2 through 4, you are to permanently discontinue treatment and promptly initiate corticosteroids for grade 2 and above. So please be mindful of these steroid recommendations from the prescribing information. There are ongoing studies of trastuzumab deruxtecan in both HER2 positive breast cancers shown on the left, a head-to-head trial, phase 3, comparing this agent head-to-head against T-DM1. So that'll be a very interesting result indeed to see if there's a winner there. On the right-hand side, this drug has been shown previously in phase 1 trials with cohort expansions that this drug, a HER2 targeting antibody drug conjugate, actually has activity in HER2 low breast cancer. That is, patients that are IHC 1+ or 2+ and FISH negative. They still have an interesting efficacy signal in early phase trials. So on the right-hand side of the slide, there's a head-to-head randomized phase 3 trial of trastuzumab deruxtecan against chemotherapy of physician's choice. So that'll be a really interesting outcome, and our center's participating in that trial, as I'm sure many of you may be as well. Next, I'll talk about tucatinib, a HER2-specific tyrosine kinase inhibitor, in contrast to lapatinib and neratinib, which are not specific for HER2 and also have overlapping activity against EGF receptor and HER4 kinase. And the EGF receptor inhibition can lead to undesired toxicities such as cutaneous rash and diarrhea. So tucatinib was designed with the idea in mind that there would be less toxicity because of the purity of tucatinib for its target. It's reversible. It's over 1,000 times more selective for HER2 than EGF receptor in vitro. And you can see the crystal structures on the left-hand side of the slide showing how tucatinib interacts with the HER2 kinase directly, but fails to engage the EGF receptor kinase just based on its chemical structure. This is the Her2 Climb pivotal trial, which won FDA approval for tucatinib in combination with capecitabine and trastuzumab. Patients with HER2 positive metastatic disease were with prior treatment with trastuzumab, pertuzumab, and T-DM1. So again, a very heavily pretreated patient population, 612 patients in total, randomized to tucatinib, trastuzumab, and capecitabine with the doses shown on the top right-hand side of the slide in the blue box versus placebo plus trastuzumab, capecitabine in the orange box. The baseline characteristics were well balanced. The primary endpoint was PFS among the first 480 randomized patients. Secondary endpoints are shown, and there was stratification for central nervous system metastasis, which were allowed in this study. About half the patients had CNS metastasis indeed in this trial. I'll show you an update of that data from ASCO. ECOG status and North America randomization versus rest of the world was also a stratification variable. These are the top line data. On the left upper side of the slide, you can see the PFS primary endpoint. This was met with statistical confidence with 5 zeros after the decimal and the p-value hazard ratio 0.54. So a very robust efficacy signal as compared to placebo when combined with trastuzumab capecitabine. So a positive trial overall. Also, the overall survival Kaplan-Meier analysis is shown on the lower left. It also met its endpoint with statistical confidence with a hazard ratio of 0.66. And then in terms of the forest plot shown on the right-hand side of the slide, you can see this is a statistician's dream data set because all of the point estimates on hazard ratios and their 95% confidence limits comfortably overlap that of the PFS population. So remarkable data consistency and really no outliers. So the FDA label indication is shown on the bottom right-hand side of the slide. It's indicated in combination with trastuzumab and capecitabine for adult patients with advanced unresectable or metastatic HER2 positive breast cancer, including patients with brain metastasis. So that's an important stipulation I'll show you in a minute, who have received 1 or more prior anti-HER2 based regimens in the metastatic setting. So not 2, but 1. So that distinguishes it from the trastuzumab deruxtecan label. These are the data presented by Nancy Lin at ASCO 2020 with regard to endpoints in the subset of patients with brain metastasis. You can see in the upper left, the overall survival in patients with brain metastasis was superior when randomized to tucatinib. On the upper right-hand side of the slide, overall survival in patients with active brain metastasis also significantly improved with tucatinib. CNS PFS benefit in patients with stable brain mets, shown in the lower left. Also, statistical confidence in this subset. And then finally, in those patients with stable brain mets, the OS was not statistically significant. However, you can see that there was a graphical trend, maybe slightly favoring tucatinib, even in this arm. Of course, none of these subsets were powered particularly well to meet these endpoints. So it's remarkable that there are so many efficacy signals in both active and even PFS and stable brain mets patients. And it could be the OS signal may need longer follow-up or is underpowered to rigorously interrogate that endpoint in the lower right-hand side of the slide. So any subset analysis you should take with a grain of salt. But in this pivotal trial, the fact is the primary endpoint was met in the intent to treat population. The overall survival endpoint was met, and the PFS in brain metastasis patients overall was also met with statistical confidence at the time of the first planned interim. So almost unprecedented in terms of the robust nature of the data set at the first planned interim analysis. Like other HER2 targeted agents, it's important to consider safety signals. Tucatinib is known to cause diarrhea, despite the fact that it has less impact on EGFR. Perturbation of HER2 alone definitely does also lead to diarrhea. We know that from experience with pertuzumab, for example, which can also be associated with diarrhea. Pulmonary plantar erythrodysesthesia was increased a little bit in the tucatinib randomized patients. Nausea was higher, vomiting was somewhat higher, stomatitis a little bit more, anorexia as well. And then also note the transaminase elevation on the far right. You do need to monitor for that and dose modify according to the package insert, please. So to put this into context, if you look at the bottom part of the middle box, starting with the metastatic disease considerations, first line is still the Cleopatra-like regimens of pertuzumab, trastuzumab, and a taxane. Second line is still TDM1 because of its ease of use, relative lack of toxicity, and robust efficacy signals, including an overall survival benefit, which we published in the original New England Journal paper and a more recent update in, I believe, one of the Lancet journals. And then finally, the third line consideration. Previously, there was no consensus or standard of care. There were multiple options. But now, with the advent of tucatinib and trastuzumab deruxtecan shown in red, you can see that for CNS metastasis patients, you may well want to consider a tucatinib-based regimens even in the second line, because that is according to the FDA label language. Moreover, you could use it in third line if you haven't used it in second line, let's say following TDM1. Whereas trastuzumab deruxtecan has such a robust efficacy signal, it carries the day for the non-CNS metastasis patients for the third line, for sure. Now, all these lines may be moved up because, as you heard in the first talk, with the likes of Neosphere, the Catherine data, the Affinity trial, et cetera, some patients may have already seen trastuzumab, pertuzumab, and TDM1 before they have a metastatic recurrence. And so accordingly, these lines may be shifted higher up, because it may not be reasonable to treat somebody who has already had TDM1 in the post-neoadjuvant setting with TDM1 again if they relapse soon in the metastatic setting. So use your judgment. You may have to do peer-to-peer contests with payers to get around the lines of therapy and help them to understand that if somebody's already had some of these drugs and they progress soon after that, it may not make sense to recycle those drugs. And since the new drugs are so active, that would be a better choice for patients. Last, I'll finish on some comments about triple-negative breast cancer, including this Keynote 355 phase 3 study evaluating pembrolizumab with either nab-paclitaxel or paclitaxel or gemcitabine carbo combination in first-line triple-negative disease. This is a placebo-controlled with randomization 2-to-1 to the investigational product. You can see the top-line data on the far right-hand side of the slide. These are in the patients that were deemed to be PD-L1 positive with a particular biomarker with a score of greater than or equal to 10. You can see that in this group, the primary endpoint was met with statistical confidence. So this is a nice data set demonstrating efficacy of checkpoint inhibition combined with various chemo agents with pembrolizumab. And so this is a potentially new registration capable trial that could expand the pembrolizumab label into the breast cancer triple negative space. In terms of subset analysis on the left-hand side of the slide, again, considering some of the confidence intervals are quite wide, there is consistency with the overall group shown at the top. Moreover, there's only 1 point estimate, that is a disease-free survival less than 12 months, that lands on the unity line, but all the rest of the point estimates on hazard ratio are to the left of 1 in this trial. So no real outliers in my opinion. And the confidence limits around the less than 12-month group were very large because it's a small subset. On the right, be mindful of checkpoint toxicities, these immune-mediated adverse events, thyroid disorders, hypophysitis, pneumonitis, myocarditis, colitis, dermatitis, pneumonitis, etc. Be mindful of these, be on the lookout and intervene early as clinically indicated. And there's important information in the prescribing instructions on management of those associated immune-mediated toxicities. Now, you'll recall that atezolizumab is approved in combination with nab-paclitaxel in first-line triple-negative PD-L1 positive metastatic breast cancer. This IMpassion131 trial was a double-blind, placebo-controlled, randomized phase 3 first-line paclitaxel, that is Cremafor paclitaxel, not nab-paclitaxel, plus or minus atezolizumab for metastatic triple-negative disease. And this was kind of meant to be a confirmatory trial of the IMpassion130 registration nab-paclitaxel atezolizumab trial. But as you can see from Dr. Miles's presentation at ESMO, this study failed to meet its primary endpoint of PFS, shown on the left. And on the right, PFS in the intent to treat population similarly was negative. So this is a bit of a conundrum and requires some explanation as compared to IMpassion130. The author's conclusion was the primary objective was not met. There was no evidence of an overall survival benefit either. I don't have time to show you that data, but the curves are superimposable. The safety profile was consistent with what's already known about these component drugs. And finally, the potential reasons for the contrast and benefits compared to IMpassion130 require further explanation. Now, the trials were different. The patient populations were somewhat different. The fraction of de novo metastatic disease, for instance, with Cremafor paclitaxel, those patients had steroid pre-medication, whereas nab-paclitaxel and IMpassion130 didn't. So there are a number of differences between the trials that might help to explain the difference in outcome. But this is, I have to say, somewhat disappointing in as much as it was, felt to be probably a confirmatory trial of IMpassion130, and it failed to achieve that overarching goal. Next, I'll talk about sacituzumab govitecan, a very, very interesting antibody-drug conjugate shown on the left. Again, with an 8-to-1 drug-to-antibody ratio with conjugation to these cysteine residues, similar to trastuzumab deruxtecan. This is also a pH-sensitive linker chemistry, and again with a topo-1 inhibitor payload, in this case SN38, which I'm sure you know is the active metabolite of irinotecan, which is in fact a prodrug. The target for this in triple-negative breast cancer is TROP2. TROP2 is shown on the far right-hand side of the slide. It's a very interesting intracellular calcium signaling modulator. It's on the cell surface, and so this antibody is directed against this TROP2 protein. And once the antibody binds, it internalizes. This is another internalizable target, just like Her2 can be internalized when treated with trastuzumab deruxtecan or TDM1. TROP2 will be internalized following treatment with this antibody-drug conjugate sacituzumab govitecan. Now, it turns out that TROP2 is overexpressed in 90 to 95% of triple-negative breast cancers. The frequency of overexpression is so high that the FDA did not mandate a companion diagnostic for measurement of TROP2 in order to use this agent. So you do not need to measure TROP2 if you're considering this as treatment for triple-negative breast cancer. This is the FDA registrational data set published in the New England Journal of Medicine last year. This is a phase 2 data set. As you can see, the objective response rate was 33 1/3 on the left-hand side by the waterfall plot, and the swimmer's plot on the right-hand side shows that there were respectable durations of response indeed amongst the objective responders. The most common adverse reactions, importantly, with an incidence of greater than 25%, were nausea, neutropenia, diarrhea. In fact, neutropenia and diarrhea are boxed warnings for this agent, so be mindful of that, please. Fatigue, anemia, alopecia in over 1/3, so be sure to warn patients of that possibility. Constipation, rash, anorexia, or abdominal pain. At ESMO, Dr. Bardia presented this data, which was the confirmatory trial of the phase 2 registrational trial that I just showed you. And this trial involved 529 patients with metastatic triple-negative disease with greater than 2 chemotherapies for advanced disease. They were randomized 1-to-1 to trastuzumab govitecan at 10 milligrams per kilogram. That is the FDA-approved dose on day 1 and 8 of a 21-day cycle, versus treatment of physician's choice with the chemo agents shown. The median number of prior regimens was 4 in this patient population, and 88% of these patients had visceral disease. The progression-free survival data is shown on the left. Hazard ratio 0.41, so a very, very profound efficacy signal. P-value with 3 zeros after the decimal. The overall survival also hazard ratio 0.48 with 3 zeros after the decimal on the p-value as well. So very impressive data. The sobering fact here is how poorly the treatment of physician's choice chemo arms did in triple-negative breast cancer. So it's a sobering reminder that chemo is not particularly effective for this disease for the majority of patients, sadly. So in summary, the metastatic triple-negative space is a rapidly moving space. For BRCA wild-type patients, we have now the FDA-approved atezolizumab-pembrolizumab combination. I put the question mark there because we don't know yet what the regulators will say about the Keynote 355 pembrolizumab data, and the atezolizumab paclitaxel data is confounded a little bit by the Impassion 131 results, which failed to confirm the 130 data. For PD-L1 negative patients, in the first and second line, you're still looking at chemotherapy, and then following 2 lines of therapy, trastuzumab govitecan can be used according to the label language. For BRCA mutant patients, which I did not have time to go over, unfortunately today for the lack of time, certainly for BRCA mutants or PALB2 mutants, we now have new data showing activity of PARP inhibitors. Both olaparib and talazoparib have been shown in the last 2 ASCOs to have activity against PALB2 mutations, which is new information that you should be aware of. And then finally, trastuzumab govitecan can be in the lines of treatment in this BRCA mutant subset, as well as potentially checkpoint inhibition with chemotherapy. So a fast-moving scenario. Immune checkpoint inhibitors are new in the landscape. PARP inhibition added to PALB2 mutants, and we have phase 3 trials underway looking at AKT inhibitors in this disease as well. So in conclusion, I've quickly shown you the update on ICAHO20 with regard to local regional control, and emphasize the importance of not necessarily eliminating that from therapeutic consideration for highly selected patients. I've shown you the trastuzumab deruxtecan registrational trial data and important safety signals surrounding that agent. I've shown you the Her2 Climb tucatinib pivotal registrational trial with very robust efficacy signals, including brain metastasis. I've shown you the Keynote 355 pembrolizumab chemo placebo-controlled trial, and the primary result from the paclitaxel atezolizumab and Impassion 131 trial, and finally the phase 3 confirmatory trial of trastuzumab govitecan, which is positive for refractory metastatic triple-negative breast cancer, which will probably, in my view, lead from an accelerated approval for that agent into a final approval for that agent in terms of regulatory considerations. I want to thank all of you for your attention during this session. Thanks again to the organizers. Binay, your work with the foundation in Nepal and India is absolutely incredible. I was so impressed by that. And thanks to our interns for making this possible and getting us through all the technical challenges of the COVID-19 pandemic era. I'll turn it back over to the organizers. Thank you.